So TB may not be considered a rare disease globally. There are about 9 million new cases a year, but in the United States it qualifies as an orphan disease because there are fewer than 200,000 cases per year, which is a great thing for the United States, but it means that there really isn't a profit motive to develop new drugs for TB because it's relatively rare in high-income countries. And so we're looking for new drug treatments for drug-sensitive TB. Currently, we use 4 drugs, and the treatment duration is 6 months, and a lot of that is given by directly observed therapy. And those drugs are drugs that were developed and progressed in the 1950s and 1960s. And then for multi-drug resistant tuberculosis, that's TB that's resistant to isoniazid and rifampin, which are our 2 main first-line TB drugs, requires an 18 to 24 month treatment, and a lot of the drugs that we use for those are very toxic and poorly efficacious. So for instance, you generally would use an aminoglycoside for an extended period of time, which has ototoxicity and neurotoxicity as common side effects. So people have to choose between being deaf or continuing their treatment to a cure, which is a terrible thing for someone to have to choose, as you can imagine. And then the companion drugs to those aminoglycosides are things like cycloserine, which cause severe CNS side effects, or psychosis, for instance, and then ethionamide, which commonly causes severe nausea and vomiting. And so you can imagine that you need to take at least 4 or 5 drugs for 18 to 24 months for MDR-TB, and those are the side effects you can imagine. Many of the people that get disease are young children or people in their 20s to 30s, so sort of in the prime of life. And then even beyond MDR-TB, now we have extensively drug-resistant tuberculosis, or XDR-TB, as you may have seen in the newspaper and in the media, and that's TB that's resistant to isoniazid and rifampin, but then also to aminoglycosides as well as fluoroquinolones. And so the treatment for that, the outcomes are very poor. It's very common that people have HIV co-infection, so they're requiring very toxic, complicated regimens together with their HIV drugs, and so it's really challenging for these patients. And even now we have, in some settings, totally drug-resistant TB, so we're kind of going back to the sanatorium days where we don't really have any drugs that are effective to treat patients because they're infected with such drug-resistant strains. I would say, though, that there's some hope. For decades, there were no drugs in the pipeline, but now in the last 5 years or so, there are several that are emerging into phase 2 and 3 trials, and these are there are some different funders for tuberculosis drug research. I mean, it's very underfunded in general, but some groups have come into this space in the relatively recent past. So the Global Alliance for Tuberculosis Drug Development, which is largely Gates funded, has helped drugs make it through the development pathway by in-licensing drugs that are being developed by companies and have some promise, and they require that there is an affordability clause with those medicines, so that once they're developed, if they're proven to be effective, that they have to be affordable to patients that are in TB endemic areas. So that's one funder, and then the U.S. government is a big funder of tuberculosis research, although there's a really big gap between what we think is needed and what is currently available for TB drug development. So there's a Tuberculosis Trials Consortium funded through the CDC, and they do drug trials for TB, and then the NIAID at NIH also funds TB trials through the AIDS Clinical Trials Group, as well as investigator-initiated trials. And then the NICHD is also funding some trials for pediatrics.